Welcome everyone to the third session of QRS quick revision series, and today's topic is lung abscess. We will go through this topic firstly. Now, what is a lung abscess? Infection of lung that destroys the lung parenchyma and which results in cavity formations and central necrosis, and this eventually results in localized area of thick walled purulent material, and this whole process leads to formation of lung abscess. So any infective pathology of lung leading to cavitations and central necrosis, which leads to localized area of thick walled purulent material accumulation, and these accumulated purulent material in lung cavities is known as lung abscess. So there are mainly two types of lung abscess: primary lung abscess and secondary lung abscess. As the name suggests, primary means which occur in previously healthy patients with no underlying medical disease or comorbidity, and these are usually solitary, while the secondary lung abscess occur in patients with any underlying comorbid conditions or any systemic disease, and these may be multiple. So 2 points to remember in primary and secondary: primary previously healthy, secondary previously any underlying condition is there, and other primary are usually solitary abscess and secondary abscess are usually multiple in nature. So the incidence of lung abscess in children is very less. It's around 0.7 per 1 lakh admissions per year. As compared to adults, this is very less. And now we have to look at the pathophysiology. What are the predisposing conditions of lung abscess? Aspiration of food material or anything, pneumonia, cystic fibrosis, which leads to decreased mucociliary clearance, GERD, tracheophageal fistula, usually H type, which presents in later part of infancy, immunodeficiencies, post-operative cases, seizure or a neurological disease, which eventually leads to chronic aspiration, any condition which is associated with impaired mucociliary defense. So these all conditions may predispose to formation of lung abscess. What is the mechanism of abscess formation in aspiration cases? So initially what happens, pneumonitis impaired because of aspiration leads to impairment of drainage of fluid of the aspirated material, and later it leads to inflammatory vascular obstruction, which leads to tissue necrosis, liquefaction and abscess formation. So initially there is what is the pathophysiology behind this? Initially pneumonitis impairs drainage of fluid. The impaired drainage leads to accumulation of aspirated material there, which leads to inflammatory vascular obstruction, and necrosis and liquefaction and abscess formation takes place. Abscess can also occur as a result of pneumonia and hematogenous spread from another side. So in aspiration cases, this is the pathophysiology, and in other side of pneumonia also it spreads hematogenously and it leads to abscess on other side of lung. Now, if aspiration, this is important point, if aspiration occurs in recumbent position, and what happens if aspiration occurs in upright position? So in recumbent position, mostly the right and left upper lobes and the apical segment of the right lower lobes are involved, because these are the dependent areas during recumbent position. And in aspiration in upright position, the dependent areas are different, so posterior segment of the upper lobes are usually involved. So in the location of abscess in recumbent and upright position, you should remember this point can also be asked in viva. And especially in table viva, if X-ray shows aspiration pneumonia or X-ray shows lung abscess, then the examiner can ask what is the difference in site of lung abscess in recumbent and upright position during aspiration. Okay. So next is primary abscesses are most often on the right side, and secondary abscesses are predilection for left side. So primary abscesses are mostly due to aspiration cases, and aspiration usually occurs on right side of the lung, and secondary lung abscesses are usually it is seen that secondary lung abscesses are commonly seen on the left side of left lungs. Now anaerobic common, just a minute, we will go through the causative agents of lung abscess. It can be due to anaerobic or aerobic organisms. Anaerobic are bacterioid species, Fusobacterium and Peptostreptococcus. Aerobic organisms include Staphylo, E. coli, Klebsiella, Pseudomonas aeruginosa, and very rarely Mycoplasma pneumonia can also leads to abscess formation in lungs. Now, what are the common clinical features? Most common symptom of pulmonary abscess in children: fever, cough and vomiting. So this can be asked in viva. So most common symptom of pulmonary abscess in children is fever, cough and vomiting. Other symptoms may be tachypnea, dyspnea, chest pain, sputum production, expectoration, weight loss and hemoptysis. These can occur in any other lung pathology also, but commonly these three features are seen initially. Now, the other, on examination, you will see tachypnea, dyspnea, retractions with use of accessory muscles, decreased breath sounds, and dullness and percussion of the affected area, crackles. Prolonged respiratory phase may be seen, and chest radiography is the key in diagnosis. And classic chest radiograph findings are parenchymal inflammation with a cavity containing air fluid level. And CT chest may provide better anatomical visualization of an abscess, including its location and size. So with chest radiography, you can diagnose lung abscess with simple plain X-ray will show you parenchymal inflammation in cavity in the air fluid level, and if you go with CT chest, then it can provide anatomic visualization, and location and size of abscess can also be determined with the help of CT. Now, wait a minute. This is for now. Difference between abscess and pneumatocoel. A thick walled lesion with a low density center progressing to an air fluid level. This is abscess. A thick wall, again go through each and every point properly. A thick walled lesion with low density center progressing to an air fluid level. While what is a pneumatocoel? Often a complication of severe bacterial pneumonia. The patient presents with pneumonia and later develops pneumatocoel, characterized by thin and smooth walled localized collection with or without air fluid level. So this is the differentiating point between abscess and pneumatocoel. And pneumatocoel often resolves spontaneously with the treatment of the specific cause of pneumonia, while lung abscess needs treatment of mostly with antibiotics or other. You will see later in this slide. So this is the difference between abscess and pneumatocoel. It can also be asked during table viva by showing an X-ray of lung abscess. Now, what is the treatment of lung abscess? Conservative management is recommended for pulmonary abscess. A 2 to 3 week course of parenteral antibiotics for uncomplicated cases, followed by oral antibiotics to complete a total of 4 to 6 weeks. So for 2 to 3 weeks, you have to give parenteral, and then 4 to 6 weeks total with oral antibiotic. Now, antibiotic of choice should be guided by result of gram stain and culture, but bronchoscopic aspiration should be avoided because it can be complicated by massive intrabronchial aspiration. So you have to look at gram stain culture for proper antibiotic coverage, but bronchoscopic aspiration is usually avoided. So initial empirical therapy should include agents with aerobic and anaerobic coverage both, because we have seen initially that causative agent can be aerobic as well as anaerobic. Now, treatment regimen commonly includes a penicillin resistant agent active against Staph aureus and anaerobic coverage. So typically with clindamycin or ticaracillin and flavulanic acid, we start the treatment. If gram-negative bacteria are suspected or isolated, an aminoglycoside can also be added. So early CT-guided percutaneous aspiration or drainage can hasten the recovery and shorten the course of parenteral antibiotic therapy. For severely ill patients, a larger abscess, or those who fail to improve after 7 days of appropriate antimicrobial therapy, surgical intervention should be considered. So this can be asked, and what are the indication of surgical intervention in lung abscess cases? These are the points that very ill patient, large abscess, or who fails to improve in 7 to 10 days of antibiotics. Now, minimally invasive percutaneous aspiration techniques with CT guidance are also available, and these are initial interventions which are required. Thoracoscopic drainage also has minimal complications, but in very rare cases, thoracotomy with surgical drainage or lobectomy and decortication may also be necessary, but these are usually the cases which presents very late or with very severe disease. Prognosis for children with primary pulmonary abscess is excellent. Primary means there was no other previous pathology or any systemic disease, no comorbid conditions, so their prognosis is very good. The presence of aerobic organism is a negative prognostic indicator, especially in those with secondary lung abscess. So aerobic organism is if found in the secondary lung abscess, then it indicates poor prognosis. Asymptomatic within 7 to 10 days. Fever can persist for as long as 3 weeks even. Radiologic abnormalities will resolve 1 to 3 months, but it can persist for many years. So this was in short about lung abscess. It can be asked for a 5-mark short note in DNB theory exams also, and lung abscess X-ray can be easily asked in viva also table viva. So you should go through this very fastly, and you can even take a screenshot of slides and make notes from them. And so for more such videos, you can subscribe to our channel Shishu Care, and the YouTube handle of this channel is @ShishuCare. Thank you very much.